Yeah, so this is Dr. Rajasree, Assistant Professor, Amrita Institute of Medical Sciences. So today, clinical case regarding Rh negative pregnancy, she is presenting. So yeah, you may start. Yeah.
This is a case of a 32-year-old G3A2 at 37 weeks and 5 days of gestation. IVF conception, GBM on OHA, Rh negative with ICT negative on 17/12/2022. Patient was admitted for safe confinement. She was appreciating good fetal movements and she had no complaints of bleeding or leaking per vaginal.
Okay, so let me know first, what is the incidence of Rh negative individuals?
Ma'am, incidence of Rh negative individuals varies with race, with it being very less in Chinese and Japanese
I'm just talking about the general instance.
In India, it is about 5 to 10%.
Okay, and what is the overall incidence of alloimmunization?
It's about 1 to 2% worldwide.
Okay, so just imagine if it is 15%, 10 to 15% is Rh negative and 2% is alloimmunization. So ideally 15% should get immunized. It's only 2% is getting alloimmunized. Why is there a difference? Okay, so first reason is that it depends on the level of fetal-maternal hemorrhage, the first reason. And second reason is the lady should be, the level at which the lady responds to the antigen. The lady, how she responds to the antigen. So second may be the reason. Third is the racial difference. That's what she's telling. So these three are the main reasons. That's why in spite of 15% being Rh negative, only 2% becomes sensitized. Okay, yeah. So you may carry on. Yeah.
Coming to the first trimester history, this is an IVF conception. Embryo transfer was done on the 23rd of April 2022. Pregnancy confirmed by serial beta HCG estimation. Patient was preconceptionally on folic acid, progesterone supplements and echospirin. And injection evaporator was also
started. Sorry to interrupt. Yeah, now she is G3A2, right? So now she is G3A2 and so this is the first antenatal visit. If suppose she comes to you at first antenatal visit. Right. So first antenatal investigation, suppose she comes to you, the first antenatal, what investigation will you order for this lady?
Ma'am, it is very important to know what the husband's blood group is. Our patient is Rh negative. It is also because she has a history of previous 2 abortions. We should know at what trimester it was, whether anti-D was administered or not.
So first the husband blood group, that's the first thing. And second, it should be documented. It's not a verbal history, my husband is negative or husband is positive. It should be documented in the first place. Second, the wife's blood group definitely, the Rh blood group and typing for the wife, the lady, documented. Husband's blood group, okay. Abortions, history of abortions, she is G3A2, right? So G3A2, so that, okay. Which trimester was the abortion taking place? Any other history?
If there was any fetal high drops or if there's history of blood transfusion.
Any other thing? If I'm talking about abortion, anything? Post-abortion, anything was done? Whether anti-D was given to her. Okay, if anti-D was given to her, if you could extract the history, how much was it given? So that is very important. Okay dear? So that should be taken into. If you can get the history, extract the history, that is more important. Why? Because now she is G3A2. That makes it more important, and that too, she is, I think, 32-year-old, and she is IVF or IVF. You said
what? IVF conception.
Yeah, so it makes us all the more relevant, I think. Okay, yeah, you may go ahead with the history, dear.
Patient was started on gliflozin 500 mg BD, which is metformin, as a part of her PCOD treatment.
Right.
Regular ANC is done in our hospital thereafter. Dating scan was done on the 25th of May and it confirmed an intrauterine pregnancy corresponding to 6 weeks, 5 days. It was corresponding to dates. NT scan was done on the 13th of July and it showed a single live intrauterine gestation corresponding to 13 weeks and 1 day.
So you mean everything was normal? You mean all ANCs were normal, NT scan was normal, anomaly scan was normal, she was over DM, managed properly. What I would like to ask you is that in her antenatal visit, was her ICT done?
ICT was done, yes ma'am, negative. It was done on May also. It was in the first trimester also. It was also done towards term.
Okay. What I would like to ask is that what do you mean by, what is the routine thing which is, and what is the routine anti-D thing which we do, antenatal anti-D prophylaxis which we counsel the lady in pregnancy? What is the routine which we do when the lady comes to you? How many weeks we should do the ICT, and whether we give anti-D antenatally or whether we give postnatally?
So in first trimester, in case there is a sensitizing event, we have to give 50 to 100 microgram of injection anti-D. Antenatal routine prophylaxis is a dose of 100 microgram at 28 weeks and 34 weeks of gestation. This is according to RCOG guidelines.
Right.
Or a single dose of 300 microgram at 28 weeks.
You haven't got my point. Suppose if a lady is ICT negative, suppose this is the lady. If I'm telling about, suppose this is the lady. Okay, this is the lady. She has come to you. She is ICT negative. You are an attending gynac. When will you check her ICT? Number one, will you give anti-D antenatally? Will you give her postnatally? When will you give her anti-D?
If she's ICT negative.
Yeah, I'm talking only about ICT negative. When will you give her?
At 28 weeks of gestation.
So there are better two schools of thoughts. One says at 28 weeks we give her anti-D, provided ICT is negative. Okay, so we give at 28 weeks, another at 32 weeks, because the lifespan is 12 weeks. So we could give an interval of 12 weeks. So one at 28 weeks, provided provided the ICT is negative. So we'll give at 28 weeks, then at 32 weeks. So by the right, she delivers at 36 weeks or 40 weeks. The other school of thought is that do not give anti-D at all. Okay, keep checking her ICT. Okay, if it is negative, allow her to deliver. Okay, check baby's blood group. Okay, if the baby is positive, then give postnatal prophylaxis. So there are two schools of thought. Now why that is so? The reason is anti-D is costly. So in developing countries, where anti-D is costly, poor people cannot afford it. So that's why this anti-D, there are two schools of thought, but preferred is to give it antenatally. Why? Because if you give it antenatally, this incidence of sensitization, it reduces beta from 2% to 0.1%. Because once it becomes immunized mother, you just cannot help it. Okay, so you got it. So at 28 weeks, you give one. Again another, you could give at 32 weeks. You got my point?
Yes.
So that is it. Okay, yeah, you could go ahead with that. Now, next one.
Ma'am, so for our patient, ICT was done at 28 weeks, that was negative.
Yeah.
And it was also done around 32 weeks and that was also negative.
Okay, right.
But anti-D injection 300 microgram was taken
Okay.
at 34 weeks of gestation.
Okay. So she had taken.
She had taken.
Okay, right. Okay. Go on.
And no sensitizing events throughout pregnancy.
Okay, so she didn't had any abruption.
No. Previous pregnancy, it was in 2020. That time she had taken anti-D. So it was not indicated during the time of IVF.
Okay, so usually I think the book says during any intervention, when any intervention is done, it always better to administer anti-D. Okay. During IVF conception, yeah, because the embryo is not in utero, better. Yeah, okay. Now, what is the minimal? I would like to ask you, what is the minimal amount of fetal-maternal hemorrhage or fetal-maternal hemorrhage required to cause alloimmunization? What is the minimal amount of fetal-maternal? Definitely, hemorrhage need to happen for the sensitizing event. So, what is the minimal amount which is required?
0.1 ml.
Yeah, so it is 0.1 ml which is required for and what are the sensitizing events? What are the sensitizing event which has to happen, which leads to the sensitizing event? What are the events?
So if you take in first trimester,
Yeah.
any first trimester
Yeah.
abortion,
First thing, second,
ectopic pregnancy,
then
and if you take any interventions done during pregnancy, such
Right.
as chorionic villus sampling,
Right.
amniocentesis,
Yeah.
even after normal delivery,
Yeah.
there can be fetal-maternal hemorrhage
Yeah.
that can cause a sensitizing
any
event.
other thing?
Abruption.
Very good. So abruption is very important. Abruption. So all these things could be. So antepartum hemorrhage. Then manual removal. When you take manual removal of placenta, all these things.
External cephalic.
So when you're intervening, all these things lead to excess fetal-maternal hemorrhage, and that could lead to more sensitizing. So the more the blood, the more blood is lost, or the more blood fetal blood mingles with the maternal blood, more chance of sensitization is there. So what are the tests done to check whether the lady is sensitized or not?
We do something called the Coombs test, and this is an anti-globulin test. So there is something called the direct Coombs test and indirect Coombs test. Direct Coombs test, you will do it on the fetal cord blood. Indirect is done on the maternal serum. So direct Coombs test, you are finding the antibodies that are already bound to the fetal RBCs, whereas in indirect Coombs test, you are detecting the antibodies that are against the RBCs that are present in the maternal serum.
Which is easy to do?
Indirect Coombs test.
So indirect Coombs test. ICT na? So ICT beta indirect. Who is directly getting affected? The baby. So direct Coombs test, it is the baby's blood. We do it in fetal blood. Okay, this is the RBC, and so this is the RBC. Over that, the antibody gets. That is a direct Coombs test. Who is indirectly getting affected because of that? The mother. So that is the antibodies which we detect in the maternal serum. That is the indirect Coombs test. So we check whether mother is immunized or not. That is the ICT. Okay. So that is the direct and the indirect Coombs test. Okay. Now tell me. Suppose ICT is positive. Chalo ICT, this is the lady, ICT we tell it is positive. First ANC visit, I am now flipping the question. Now ICT is positive. Now first antenatal visit, the lady is ICT positive. Now you are perplexed, this is lady's ICT positive. Now what will you do next? Now ICT is positive, what will you do next?
ICT is positive, then you start checking for titers.
Very good. So next thing will be, you check the titers. So what are the critical titers at which you should be cautious? What are the critical titers you should be cautious? What are the critical titers whereas you should be cautious?
1:32.
1:32. So some labs says 1:60s. The other lab says 1:32. What is the sweet 16? Sweet 16 is the age. So some says sweet 16. Yaad rakhna. 1:16. Some says 1:32. At least wo yaad rakho. 1:16 or 1:32. Okay. So till that level, you can wait and watch. Okay. And when or how frequently you should check the titers, beta? How frequently you should check the titers?
Every 4
weeks. Every month, na? Every month. Every 2 weeks, no point. So every month you should check the titers. Okay. The moment 1:16 it reaches, what next? You will change to what? You start with what will you do? You start checking with your ultrasound. Okay? You start checking with your ultrasound. You know that now your baby may be anemic. Okay? So you start checking with your ultrasound.
Once we reach a critical titer of 1:16 or 1:32, we have to start monitoring the middle cerebral artery peak systolic velocity. So the reason why middle cerebral artery is chosen because it is easy to identify on scan, visualize on scan, and the cutoff for MCA-PSV is 1.5. 1.5.
Yeah.
So we have to scan for MCA-PSV every 2 weeks until 1.5.
Okay, right. Yeah. So we choose MCA-PSV or middle cerebral artery peak systolic, not volume, velocity. Okay, and more than 1.5, right? Multiples of median, है ना? So why we choose this? Because एक तो ये है, one reason is that it is easy to visualize, and second is that see beta, baby is anemic, है ना? Hyperdynamic circulation, so heart beats faster. Point number 1, है ना? Point number 2 is that preferential what we say, preferential circulation to brain. Third is that because of lysis, blood becomes thin. Up, you just imagine the consistency of honey, just imagine the consistency of petrol. Which flows faster? Petrol will flow faster. So that because of that, velocity increases. So that is an indirect indicator that blood is thin. Okay. Here also same formula is applied. So that systolic velocity increases. So multiples of beta 1.5. So that cutoff figure is 1.5. So if it is less than 1.5, we can still wait and watch and continue with pregnancy. We could still push on with the pregnancy because in utero babies, still we want the baby to be in utero. It is a safe environment for the fetus to be in utero. If it crosses 1.5, what next, beta?
You will do an intrauterine transfer.
Excellent. Okay, so you have planned for an intrauterine transfusion, right? But which blood you will use for intrauterine transfusion? Which blood you will use?
We will use a gamma irradiated O negative blood.
Okay, so you have planned for intrauterine transfusion. How frequently, first of all, how frequently you will monitor this MCA PSV? First point.
Every 2 weeks or 10 days.
So every 10 days to 2 weeks, you will monitor this MCA PSV. You will keep a close watch on this MCA PSV, right? So if it is increasing and if it touches if it is suppose 1.2, 1.3, you will be watchful. If it is 1.5 and going below, immediately you will alert, okay, it needs a blood transfusion. Okay, time for a transfusion. You are starting transfusion. You said gamma irradiated O negative blood. Where?
Into the umbilical vein.
Where? Which site?
Placental.
Very good. Why are you choosing that site, beta? Why are you choosing that site? Placental site. Why are you choosing that placental site? Why are you choosing that?
Easy to
access first, and that is the stable site. If you choose that loose umbilical cord which is floating, okay, that inadvertently will cause bleeding and will cause an intrauterine death also. So this is a fixed area. It is easy for you to do an intrauterine transfusion. Okay. And how long will you continue this transfusion, beta? Any period of gestation?
Up to 34 weeks of
excellent. So up to 34 weeks period of gestation, you could apply for intrauterine transfusion. Very good. Okay. Now tell me the hazards of intrauterine transfusion. What are the hazards of intrauterine transfusion?
Ma'am, like you mentioned, any inadvertent injury, so it can cause IUD,
then
it can cause bleeding,
right? Then
infection.
Very good. Then can it cause abruption? Can it cause preterm labor?
It can cause abruption. It can cause preterm labor.
Yes. So all these intrauterine transfusion can cause also there's some inherent risk. So we have to be careful. It can cause anesthetic problems also. So we have to be cautious about the intrauterine transfusion. Okay. Now, so you could carry on with your history.
Her past history is significant for she's a known case of polycystic ovarian disease. And in her personal history, she had regular menstrual cycles. ET was done on the 23rd of April and her estimated date of delivery was on the 14th of January. Patient was married for 6 years. It was a non-consanguineous marriage.
Anything relevant in the personal history, blood bowel, everything is normal?
No. It's just in 2019 and 20, she had history of abortion and anti-D was taken for both. Patient is A negative, husband is B positive.
Okay, right. Any specific history of blood transfusion, anything done?
No.
Nothing?
In pregnancy, no. No history of APH.
Okay. Have you done general examination?
Yes, ma'am.
Okay. So everything was
General
normal?
examination was fair.
Breast examination, everything was good. Okay, go ahead. Right. Jen?
Ma'am, her vitals were stable. Per abdomen, uterus corresponding to term, cephalic, mobile. Uterus was relaxed. Fetal movements were perceived and FH was confirmed with Dopplers.
Okay.
PV done, the cervix was soft, posterior, 25% effaced, one finger and vertex was above brim and pelvis was adequate.
Okay, right. And then what was did she undergo cesarean or was she a normal delivery?
Ma'am, we had induced her with Foley's and 2 doses of PG.
Right.
And oxytocin augmentation was also given. But then, view of non-progression, we had taken her up for emergency LSCs.
You took her up for emergencies, yes. Okay, ठीक है. So I would like to ask you questions like regarding RH negative pregnancy, what all precaution you will take when you are handling this RH negative pregnancy? You are doing a cesarean section for her, right?
Yes, ma'am.
So what all precaution will you take?
So our idea is to minimize the fetal
Yes,
maternal
yeah, that's
hemorrhage.
right, yeah.
So we can give methergine.
We can give methergine or methergine is contraindicated.
Oh, methergine is contraindicated.
Yeah, so point go on. Yeah. Next
Yeah.
one.
And apart from that, while drawing blood, you should ensure that the cord is wiped with the sterile mop, held with the sterile mop, and only then
Yeah.
drawn.
Anything?
Early cord clamping.
Okay, excellent. Anything else?
That's all.
Anything? Okay. When you put incision, beta, after you put incision, usually mop should be kept by the side so that spillage. Okay, spillage of the maternal blood to the fetal blood. When you put incision, the maternal blood may come in contact with the placenta of the fetus. Okay, so that spillage should be avoided. Okay, so all these things, methergine should be contraindicated. And manual removal of the placenta, massage nicely so the placenta delivers spontaneous delivery without any too much of traction. It should be delivered. So don't try to remove the placenta manually. As far as possible, gentle removal. That's what the book says. Gentle removal of the placenta. I don't know what the meaning of the term gentle removal, but the book says gentle removal of the placenta. And the methods is contraindicated. Early cord clamping should be done. Okay. So now I would like to ask you is that how should the anti-D, okay, okay. After that anti-D was, did you confirm the blood group of the baby?
The baby's blood group was RH positive.
Okay.
So we had given anti-D.
She was administered.
She was given.
So let me know, now we are saying anti-D, right? How should anti-D be administered and let me know how it is stored.
So anti-D should be stored at 2 to 8 degrees Celsius.
So it means it is a cold storage, right?
storage.
It is cold storage. We have to understand it is a cold storage. You cannot stack here and there like in our table. So it is cold storage. Point 1, point 2. Administration.
And it is administered deep IM into the deltoid.
Very good. So deep IM into the deltoid. So you have to be very careful. You cannot use subcutaneous something, right? So if a lady has a bleeding disorder, suppose if this lady, she is having a bleeding disorder. So how do you administer now? So book says that you can have a subcutaneous or a intravenous, but preferentially intramuscular is the preferred route. But if she is having some bleeding disorder, we can have a subcutaneous or intravenous, but preferably deep IM in deltoid is preferred route. Okay. Now another thing which I would like to say is that how long does this anti-D last?
It lasts for 28 days.
24 to 28 days it lasts. And could you tell me that how much ml will we give for this fetal maternal hemorrhage? There should be some calculation. So how much is the calculation?
So 300 microgram of anti-D can neutralize 30 ml of blood, which is like 15 ml of RBC.
So very easy to remember. 300 microgram, 30. So 300 microgram of anti-D, 30 ml of blood, 15 ml of RBC. So that's all. Okay. Acha. So that's what. Okay, na. And if suppose, how will you give? Like when should you give? Suppose this lady delivered just now. So you will give now, after 24 hours, after 1 week, after 1 month or 1 year. When will you give?
It should be given within 72 hours.
Very good. If not given within 72 hours, what will you do?
It is always better to administer if the baby's blood group is positive.
If not within 72 hours, then what do you do? If I have forgotten, if I haven't given within 72 hours, then
you can still go ahead and administer.
Give at least within 28 days. Okay, so at least within 28 days, you should give anti-D. Okay? Yeah. So now I would like to ask you one thing that now in spite of giving anti-D, mother becomes ICT positive in the next pregnancy. So what are the reasons?
So one reason can be that the administration was not proper.
What do you mean by administration not proper?
So the dose would not have been proper and the route, deep IM, it might not have been given deep iron.
Deep iron.
Sometimes subcutaneous.
Yeah.
It would have gone only to
Yeah. Okay. Then.
This anti-D should be stored at 2 to 8 degrees.
So there could be a storage
problem.
Yeah. Then.
The calculated fetal maternal hemorrhage would have been more.
Yeah. So means that you have fetal maternal hemorrhage would have been more. And you could have given just the 300, actually it would have required much more than that.
Yes.
So sensitizing event would have been a big one. The dose would not have been adequate. So dose problem, root problem, then the sensitizing event could be, so there are a lot of other problems that could be the reason for the, okay, take. So that's it. Yeah. So now we have, the lady has delivered, okay, now baby is out. We have done early cord clamping, we have said we have to take precaution in RH negative pregnancy, so we have taken precaution, baby is out now. So what are the tests now to be done on the baby? We have to do test on baby, right? So what are the tests we are doing on the baby?
So from the blood drawn from the cord, we have to check a complete blood count. We have to do ABO testing and RH testing also. We have to check for bilirubin, DCT, and manual counting of reticulocytes.
So very easy to remember. A, B, C, D and
Reticulocytes.
So ABO system, RH system, B से bilirubin ले लो, C से क्या जी CBC, D से
DCT.
DCT और लास्ट में बचा हुआ क्या है रेटिकुलोसाइट को. So A, B, C, D operate reticulocyte. Just remember like that. ठीक है ना? So that's it. अच्छा. Have you heard about one test used to check the feto-maternal hemorrhage?
There is a test that's called clear bed case.
Very good. So just let me know. I don't want to go in detail. Just let me know the rough overview, roughly what is the crux of that test. Do you know any idea about that?
Yes, ma'am. So clear bed case test is to estimate the feto-maternal hemorrhage. The basic concept is when you use alcohol, it will elute the maternal RBCs but not the fetal RBCs.
So the maternal RBC look like a ghost and the fetal RBCs will still be in there.
Red and
So in the low power field you will be seeing the
count.
If you count.
After you fix it, you will count manually.
So that is known as the clear bed test. Okay, so that is it. Okay, so now this lady delivered. Okay. You gave anti-D, you took a DCT, everything. She goes back home, everything is okay. She comes back, okay? We deliver second time. After second delivery, she wants sterilization. Now, would you administer anti-D or not?
We have to administer anti-D because in case of any adverse outcomes in her life, like losing a child or something like that, she might want to recanalize and go for pregnancy again. That time this will ensure that.
Very good. So anti-D should be administered usually, but if she refuses, the better
consent should
be taken that you are not giving, and definitely it should be written that anti-D not given. Okay, so that's it. Okay, now. How does RH alloimmunization occurs in first pregnancy? So how does it occur in first pregnancy and why the first pregnancy is spared?
So usually when the maternal RH negative blood comes in contact with the fetus's RH positive blood, there's a alloimmune response.
That's for the first time.
For the first time. And the antibodies formed in this response is normally IgM.
Okay.
And these IgM antibodies will not be able to cross the placenta. So, moreover, the first pregnancy is spared and maximum fetal maternal hemorrhage occurs during the time of delivery. So, that is why the first pregnancy is spared. Okay. And even if IgG antibodies are to be formed, they will only be formed after 6 months. From the time of this response.
So when in the first pregnancy, even if fetal-maternal hemorrhage takes place, IgM is formed. It is saline soluble antibodies. It is big antibodies. It does not cross the placenta, right? And the second antibody which forms after some time, recognition takes place, forms after some times. It is the IgG antibodies. which are, I think, albumin soluble antibodies, right? And it is big enough. Okay, it does not cross the, it crosses the plasma. Oh, sorry, it is small antibodies, it is incomplete, we call it as an incomplete antibodies, and it crosses the placenta. That appears in the second pregnancy. Okay, so that's why first pregnancy is spared. That is the main reason for it. Okay, and I would like to ask you one more thing. Why not anti-D we usually give after 28 weeks? Now, when ICT is negative at 28 weeks, then we give anti-D prophylaxis. So, why not anti-D given before 28 weeks?
It is told that the risk of sensitization prior to 28 weeks of gestation is just 0.1 percentage, and fetal RBCs start expressing this anti-D antigen only after 28 weeks.
Yeah.
So if you take cost effectiveness into consideration, it is not recommended.
Okay, so that's a correct thing. Okay. Now I will just flip the question. Let us guess that the lady is Rh positive. So can she have a chance that she may be having an Rh negative child?
Yeah, so if the lady is Rh positive, she can be either homozygous positive or heterozygous positive. Heterozygous positive means that she has plus and minus in the chromosome. So if she gets, if an Rh positive mother gets married to, let's say, a homozygous negative blood group father. So, and if the lady is also heterozygous positive. In that case, there's a 50% chance that the baby will be Rh negative. But if the mother is also heterozygous positive, the husband is also heterozygous positive. In that case, there is a 25% chance.
So she may be having, right? So if the only thing where she will never get a positive child is if she is homozygous positive, she will never have a negative child. If she is heterozygous positive, she will have a chance of a negative Rh negative child. So this pregnancy was managed nicely. She was given anti-D, and baby was doing well. Right?
Yes, ma'am. Yes, ma'am.
So now, suppose the lady was from village and it was not managed properly. She didn't receive anti-D. Maybe developed anemia, right? So tell me the spectrum of fetal affection in Rh negative pregnancy. If antibodies are developed. So tell me the spectrum. How does that happen? So, fetal anemia happens, and then tuberculosis fetalis happens. So tell me the spectrum. How does it evolve?
Yes, ma'am. So in its mildest form, it presents as fetal anemia, and there is no jaundice in the fetus. In the less severe form, it can present as icterus gravis neonatorum, which is pathological jaundice. And in its most severe form, it is fetal hydrops.
Okay. So what are things? What happens actually? Anemia happens. Hyperdynamic circulation happens. Okay, there is a lot of hemolysis which is happening. So what is happening? Where does this intravascular compartment shrinks? What's happening? Extravascular compartment, the albumin level goes down. So what is happening?
Extravasation, third spacing.
So third space compartment increases. So now what happens?
That's why the fetus develops ascites.
So third space compartment. So what all effusions will happen now? Tell me. Physiological, no.
It will start with from head to foot cerebral edema, ascites, pleural effusion,
pericardial effusion, pleural effusion, ascites, all these things. Hepatomegaly. Why hepatomegaly?
Hemolysis.
Hemolysis also. Then any other thing?
Production of RBCs.
Yes. Then splenomegaly also will happen. Okay, so all these things. Then bilirubin also. Why? Because RBCs are broken down. So all these things will happen. Okay. What do you know Buddha sign?
Buddha sign is seen in fetal hydrops.
So that's it. Okay. Yeah. So we have discussed this Rh negative pregnancy. So let me know what are the recent advances in the Rh negative pregnancy.
So the first is the diagnosis of fetal blood group as early as 16 weeks of gestation by cell-free fetal DNA.
Cell-free fetal DNA, yeah. Cell-free fetal DNA. This could be asked in entrance exam also, yeah.
Then there is direct estimation of Rh antibody rather than checking ICT. Then there is flow cytometry to calculate fetal maternal hemorrhage rather than Clear-Beck.
Okay.
and other non-invasive tests like MCA-PSV instead of amniocentesis can be employed to guide our treatment.
Mind you, that is a non-invasive test. It's nowadays, which is just MCA, PSV is a non-invasive. In our times, it was Lilly's chart, which was invasive. Yeah. Then
next is intravenous IVIG therapy.
Yeah. So that blocks the fetal reticuloendothelial system. Okay. So these are the recent advances. Yeah. So to conclude this session, certain important points. So the incidence of Rh negative pregnancy is, we have to revise, 5 to 10% in India. And mind you, see, the incidence of Rh isoimmunization is only 1 to 2%. See? And so now just concentrate here, 1 to 2%, and only 10 to 15% of this Rh negative ladies develop alloimmunization. The reason could be asked. So it is ABO incompatibility is one of the reasons. The dose of inoculum is insufficient. Okay, the strength of the stimulus may be weak enough. So that may be one of the reasons that the lady is not responding. And see, the 30% of these ladies, the Rh negative ladies, may be non-responders. Okay, so this may be the reason, right? That's why, in spite of these being 15%, this being 1 to 15%, only 2% may develop this. Okay. Now, what is this routine? Now, again, revision, routine antenatal anti-D prophylaxis. So, once an Rh negative lady comes to your clinic, see the partner is Rh positive or not. If it is negative, just leave it. But if the partner is positive, in the first booking visit itself, do the ICT or the indirect Coombs test for the antibodies. Okay, whether his mother is sensitized or not, or immunized or not. If it is positive, we will deal with it later. If it is negative, what is to be done? So, if it is negative, screen every 4 weeks. And continue till 28 weeks. Okay, continue till 28 weeks. Now, again, there are two things. Either you could go a single dose regimen where 300 microgram single dose at 28 weeks, or 2 dose regimen 100 microgram at 28 weeks and further a second dose at 34 weeks. Now this should be a preference, this should be preferred. Okay, or as I told you, because anti-D is costly, sometimes in developing countries, okay, developing countries, some people may not prefer, the patient is not affordable, so postnatal prophylaxis after the delivery of the baby. Once the baby is positive, the baby's blood group is positive, then we give the anti-D prophylaxis. Okay, now so let us go back now. If the lady is positive, what is to be done? So once, if ICT is positive on the booking visit, so what is to be done? Repeat ICT every 4 weeks, every month. If the titers is below critical level, what is the titers below critical level? I told you 1:16 or 1:32. Okay, 1:16 is preferred, but lab values differ, depends on the lab value. Certain labs take 1:32, certain labs take 1:16. Okay, so till 16 to 20 weeks we take ICT. Thereafter we switch on to MCA-PSV. This is the full form of middle cerebral artery peak systolic velocity. Why we take this? Because it is to visualize, and usually it increases in case of Rh negative pregnancy was sensitized. Why? Because of anemia there is hyperdynamic circulation. Okay, because of anemia, because hemolysis of fetal RBCs takes place, so viscosity decreases. See, viscosity decreases, therefore velocity increases, and hyperdynamic circulation takes place, and there is preferential circulation to the brain. So because of this, the MCPSV increases. Okay, so here we follow with this ultrasound. This is non-invasive method. Okay, so we go with this and we take a cutoff of 1.5 multiples of median. Okay, so if it is less than 1.5 multiples of median, less than 1.5 multiples of median, then we repeat this ultrasound every 1 to 2 weeks, preferably every 10 days. Okay, and continue with the pregnancy. Very good. But if it is more than 1.5 multiples of median, then we plan for an intrauterine transfusion. Okay, we carry this pregnancy till 34 weeks and thereafter give antenatal steroids and deliver the baby. Okay, so these things, these important things you should be able to at least understand. Okay, now what are the, again this is a question, there could be a question. What are the conditions that bring significant feto-maternal hemorrhage? At least these points you should remember. Miscarriage, it could be elective abortion, it could be an ectopic pregnancy, important, see threatened abortion where could be a bleed inside and again it could have settled, but there was a bleed, okay, and pregnancy could have gone through uneventfully, but there could be a bleed, so threatened abortion. There could be, see we have done a procedure, chorionic villus sampling, it could be amniocentesis, fetal blood sampling, see this is again a procedure. Okay, now antepartum hemorrhage, see there are two things, placenta previa, abruptio placenta, blunt maternal trauma. Okay, she wouldn't have told you, but there could be a trauma which could have settled, but it could lead to immunization. Again, a procedure which is done by gynec, external cephalic version, iatrogenic, C-section, cesarean section, normal delivery, very high chance. This is the maximum chance where they get a fetal hemorrhage, manual removal of placenta, stillbirth or intrauterine death, and a molar pregnancy. So these are the conditions that bring a significant feto-maternal hemorrhage. Now, when you are working in a setup, okay, when you are working in a setup, what are the ways to minimize feto-maternal hemorrhage? How could you help? So I am just talking about at your level, okay. So during delivery and during C-section, when you are seeing what you could do. So immediate cord clamping. Okay, you could do an immediate cord clamping. Keep the cord long. Okay, so that suppose if any procedure, any cannulation need to be done, at least cord should be long enough. Okay, then avoid methargin. Why fetal blood, the moment uterus contracts, there could be migration of the fetal cells into the metal circulation. That will invite more immunization. Okay, beta. So that's why just avoid methargin. We should not give methargin. Okay, and wait for spontaneous separation of placenta. Don't meddle with the uterus. So you could wait for the spontaneous separation of placenta, right? And at cesarean section, how could you avoid this? What precaution will you take for Rh negative pregnancy? We could minimize or avoid blood spill into the peritoneal cavity by packing. Again, wait for the spontaneous separation of placenta and gentle handling of the uterus. So in crux, what should be done? Now, one important last thing is that if possible, if the mother is ICT negative, see she is not immunized, so give anti-D prophylaxis at 28 weeks. That is very, very important.